In Magdalena? Yes? Okay, so welcome everyone. Welcome to this webinar organized by Centurion with our distinguished faculty, which we will allow them to present themselves very soon. This webinar is being recorded, so if you feel okay with that, please keep your camera on. If not, please turn your camera off. We will share this webinar later in different settings, so I just want to inform everybody about that before we continue. But a very, very big warm welcome to everyone to this webinar about abdominal wall closure, and the topic of the day is, are you closing the right way? And my name is Pan Hermansson. I'm the CEO of Centurion. We are a company that is developing technology for fascia closure after open abdominal surgery. And obviously this is a topic that is very close to our heart, where we feel there's a lot of work to be done. And the vision of Centurion is to facilitate and help surgeons close the abdominal wall in a better way. Please mute your microphones if you're not speaking. Yes, I will start by allowing the faculty for today present themselves. And we're going to start with Dr. Andrea Stewart first. Andrea, please.
Hi, my name is Andrea Stewart. I'm a gynecologist and I work as head of the Department of Gynecology in Helsingborg, Sweden. We are one of Sweden's larger benign centers for surgery. So I mostly do surgery, gyne surgery, and I do obstetrics when I'm on call. I'm affiliated with the University in Lund, where I'm associate professor at the Department of Obstetrics and Gynecology. And I also work mainly, my research projects are mainly on gyne surgery. I have some obstetrical PhD students as well. It's very nice to be here today, and I hope that we can deepen and broaden everybody's and our own knowledge about how to close the abdominal wall. Thank you.
Perfect. Thank you, Andrea. And we'll move over to Professor Jan Bakkeland. Jan, would you please introduce yourself?
Thank you, Pan. Good afternoon, everybody. Very excited to be here. My name is Jan Bakkeland. I am a gynecologist. I was trained as a gyne-oncologist. I work in Melde Hospital, which is a medium-sized hospital in Belgium, just north of Brussels. I'm affiliated with the University of Leuven and Leuven University Hospitals as well. So I do pelvic oncology surgery, but I'm also involved in benign surgery. My research the last years has mainly focused on venoed vaginal natural orifice surgery. But for the oncology, I do quite a bit of open surgery as well. As a disclosure, I am an advisory board member of Centurion, and I must say it's been an experience where I've learned a lot about fascia closure, and I hope we can transfer that knowledge to everybody on how we as gynecologists should be closing the fascia correctly, because I think lots of us, me included, up to recently, weren't doing it correctly.
Great. Thank you very much, Jan. And then last but absolutely not least, we're going to move over to our third faculty member of the day, and that is Dr. Gabriel Berner. Gabriel, please.
Hi, thank you for letting me be here. My name is Gabriel. I'm a trauma and emergency surgeon in south of Sweden, colleague of Andrea at Helsingborg's hospital. I deal mainly with emergency and trauma surgery and endoscopy, and I'm a PhD student at Lund University, and the research evolves around optimizing abdominal closure after open surgery. I'm also a clinical advisor and founder of Centurion. Thank you.
Great. Perfect, Gabriel. Before we move into the conversation and the Q&A, we have a little bit of a short presentation by Andrea, which we think would be appropriate in this situation to level set everyone on the evidence and the guidelines that do exist in this field. So I'm going to move the slides forward here. And then I'm going to ask Andrea to present. Or I have to probably ask Magdalena, could you please move the slide forward? Oh, there we go. There's a little bit of it. Try again. There we go. Perfect. Thank you.
Okay, so let's see if we maybe take the next slide. Thank you. So I work as a gynecologist, and I was surprised when I started to read more about the literature how common actually hernia is after abdominal incisions, and in particular midline incisions. Depending on the patients, the incidence is 10 to 23% after abdominal operation, and it can be even higher depending on what type of patient one is operating. In the US, 350,000 hernia operations are performed annually, and this is just for incisional hernia, so that we have caused, basically. It is associated with a high patient morbidity and also a burden on both financial, but also time-wise on the healthcare system. And of course, strangulations of the intestines can be lethal. So this is something that's common, and it's potentially dangerous, and we are partly causing it. So what can we do to prevent it? Let's see if we can switch slides. So there are, of course, factors associated with the patient. They should stop to smoke, to lose weight, especially if they can do this pre-op. And of course, they should become younger, healthier, and more fit. And what can we as surgeons do? So there are a couple of things we can do. The first is to prevent surgical site infection, and surgical site infection is one of the main risk factors or a precursor to the formation of a hernia. So with antibiotics, the correct cleaning, draping, etc. And then also to how to suture and close the abdominal wall is the next part that we can do. Now we can change slides. So I'm going to just if you remember the take-home message, then you don't have to remember very much more. And in the end, we can arrange so you can get the references. And basically, there are two larger randomized controlled studies comparing small tight bites or larger bites that are about 1 centimeter from the wound edge. And the evidence concludes that to avoid surgical site infection and to avoid hernia, one should take small but mini bites. The stitches should be 5 to 8 millimeters from the wound edge and only include the aponeurosis in the stitches, so no fat, no muscle. And one should use a monofilament, long-lasting suture, for example, PDS 20. And one should make a running suture, so not interrupted sutures, with a suture to wound length ratio of at least 4:1, preferably more. So if you can remember this, that's basically what you have to remember. And as I said, we can go through the references. You can get them later. Thank you.
Great. Thank you very much, Andrea. And indeed, to your point, these 4 messages here are critical to good abdominal wall closure. And we're going to move to the next slide, please, Magdalena. So we want to start the discussion in the faculty, and I'm going to ask a question to the 3 of you. And well, actually, I'm going to ask it to Jan to start with. Why do you think there is this gap between how to close and the knowledge of the actual how it's being done in a normal practice?
Thank you, Pan. I think there's probably multiple reasons. I think probably the main reason that it's not in the forefront of our focus hernia is because we don't see our own complications, and we see other complications, but the hernias don't occur immediately postoperatively often, and then the patients go to a hernia surgeon. They don't come to us. So I think all of us underestimate our own incidence of hernia, and that reduces our awareness of it. I think also at the OBGYN conferences, a lot of the focus these days goes to minimally invasive surgery, it goes to robotic surgery, it goes to endoscopic surgery. There's not a lot of focus on open surgical techniques to keep us up to date. And I think like the hernia surgeons at their conferences, they all know these references that Andrea referred to. But I think many gynecologists, if not most of them, are not aware of this evidence or do not read up on this evidence. So I think many of us still suture the fascia the way we were taught, some quite recent, some very long ago. And because we don't see that many complications, we're not that focused on it. So I think that is probably the main reason why this hasn't become the standard. And maybe some people in the audience do use these techniques already, but if I see around me and in many hospitals where I go to, it's not being done. It's people do it differently, and then there's many different ways, but this definitely isn't the standard, I think, in gynae practice.
Thank you, John. What do you think, Andrea? What's your perspective on this?
No, I agree. I think I think that since we don't diagnose and treat the hernias and the complications, we're not aware of the complications, and also it's many of the cesarean sections are done at 3, 4 in the morning, and it's a young colleague that's stressed and is on call at the delivery ward, and oh, the baby's out, the baby's healthy, just time to close now and run up to the delivery ward again. So I think there's also a surgical tradition how we've organized our specialty, and that we don't really let it take time to close the fascia. And then, as Gabriel, as you might mention later, the risk of hernia is lower after a Pfannenstiel incision than after a midline incision. So in that way, we're also we have an easy population to deal with.
Yeah, indeed. I'm going to let Gabriel comment on that as well, and being maybe a little bit more aware of the guidelines than the typical gynecologist, because it's part of Gabriel's research. But Gabriel, please comment.
Both the randomized trials that you showed, the Dierenberg study, the Dutch from 2015 and the Swedish study from 2009, showed a reduction in wound infection if you avoid including muscle and fat tissue in your bites. Is there what about incisional hernia is one thing, but what about SSIs after cesarean section, wound infection? Is that common? Would you find
I-
a special like a niched cohort of patients that would develop wound infections?
I think skin incisions aren't that common. But if we look at we've looked at our infections after cesarean sections in Helsingborg, the hospital I work at, and a planned cesarean section have about the same infection rate as a vaginal delivery. An emergency cesarean has about 15% of the patients are given antibiotics 6 weeks after the cesarean. And if it's a real emergency cesarean that you have 10 minutes to get the baby out, 29% get antibiotics. It's mainly not the skin, but it can be endometritis, urinary tract infection, or just fever. We don't exactly know the diagnosis. So it's quite dirty surgery, and we give a lot of antibiotics after cesarean, not planned cesarean, but emergency cesarean.
I think, you know, we have a subgroup that's increasing where we see lots of wound infections, and that's our obese population. And I think, you know, that's a population that's increasing year after year. And those are the patients where we're mainly worried about the wound infections and probably about the hernias as well. But I think that's a group we mustn't underestimate globally, because as you said, you know, the incidence of hernia after Pfannenstiel isn't that big percentage-wise, but there's a whole lot of C-sections being done globally. So I think if you look at a total number, the incidence of hernia after C-section in total is actually quite big, and it does have a big impact on the healthcare systems. And then since you asked subgroup, you know, I think it's mainly the obese population that's growing and growing every year that we need to focus on.
Actually, we have, sorry, Andrea, we have a question from the audience already, and I think that's great. So yeah. I really want to allow Diogo. You have a question, please go ahead.
Yeah, hello, good afternoon. Well, thanks very much for that presentation. I'm Diogo Aires de Campos from Lisbon in Portugal. I was intrigued with the two studies that you were mentioning, and unfortunately I was not aware of, regarding the different types of technique for suturing the aponevroses. And I wasn't very clear to me what the main outcome was in those studies. Was it surgical site infection, or was it hernia? And again, also, what was the control group? What were they doing in the control group?
That's a good question. Yeah, thank you. And Andrea or Gabriel, you want to comment?
I can answer.
Yeah.
So basically, there's two randomized studies, one from Sweden, one from Holland, with about 500 patients in each study. So it was randomized between big bites and small bites. And big bites were performed with a big needle and small bites with a small needle. So the small bites, the thing with the small bites is to only include the aponeurosis in the midline. And in both studies, I think it was 50% reduction of both incisional hernia and wound infection. So by adding maybe 10 minutes or so to the operating time and be very thorough, you can have great impact for the patients.
Thank you very much.
Did that answer the question, Diogo? You're happy?
Yeah, absolutely. Yeah, thanks. Very clear.
Perfect. Great. There's actually one more question coming in through the chat. So again, very happy about that. That's the type of webinar we want to have, very interactive. I'm going to ask this to you, Andrea. What is your suggestion about routine prophylactic antibiotic therapy?
For cesarean?
It doesn't say, but I guess it's cesarean.
I guess.
Yeah.
So we've followed the Swedish national guidelines, which is Dr. Sillen, ampicillin for planned cesarean. But after looking at that, we have such high post cesarean infection rates, we've actually started to give cefotaxime and metronidazole for emergency cesarean. I don't know how you do, Jan, in Belgium.
The Belgian habit, I think, in most centers, especially here, is we give cefazole, second generation cephalosporin.
Yeah.
For C-section. No.
And when it comes to preventing surgical site infection, there's also been a RCT comparing for obese patients, comparing the use of a negative pressure device, which I was hoping actually would have an effect, but they ended the study after including 1,600 patients because there was no difference in obese women after cesarean if they had a negative pressure device used or just a standard wound treatment or wound bandages. So weight loss is the treatment.
Okay. Yeah.
Can I ask a different question, Pan? And it's actually for Gabriel. In the introduction, Andrea, you spoke about the 4-to-1 ratio, and I think for everyone who's a lot involved in hernia surgery, that's become a common habit. But Gabriel, could you just explain? Because I think for many gynaes, it's not as obvious as it sounds. I know the first time I heard it, I was like, what does that mean, 4-to-1 ratio?
Yeah. So what you want to achieve is that you want first you want to avoid having muscle or fat tissue in your bite, and you want to spread the tension in the wound on many small bites. So and we know that if you put more than 4 times suture length, then the wound is long. I mean, okay, so if you have a 10 centimeter long wound, you should have 40 centimeter or above 40 centimeter long suture line. That is the kind of cutoff for reduction of incisional hernia, wound rupture, and wound infections. And basically, you can achieve this by using a small needle. In the Ethicon catalog, that needle would be called CT2. Instead of using the big needles. That's a very easy way to achieve small bites, and to make sure that you actually put enough thread in the wound. You measure how much thread you did put in the wound and divide it with the length of the wound, so you get a ratio. And if that ratio is above 4, you did well.
Okay, we actually have a short video here of the correct closure technique of the 4-to-1 ratio. So Magdalena is starting the video here, but please, Gabriel, please continue to comment.
And may I just say a comment in the one of the RCT, the RCT from Holland that was published in Lancet, in the small stitch group, they even had a ratio of 5. So that it was very small, tight stitches. Can we make them too tight, Gabriel? Or do you think?
Yeah. Okay. So there are some experimental studies that I think if you are between 4 and 8 if you have a ratio between 4 and 8, I think you have a stronger, or it has experimentally been shown to be a stronger wound compared to less than 4. But it doesn't really make sense to have a higher ratio than 8. That would take very long time, and I mean, you will also perforate the fascia. So and the data suggests that you should have a ratio above 4.
Yeah.
And that is for midline incisions. And
yeah, it's only been shown in midline incisions, yes.
And there we take only the anterior aponeurosis. Yeah, if you have an anterior and a posterior, you only take the anterior.
Yeah, but that's also debated. One important thing which is more and more adopted is that when you make your incision, you go down to the aponeurosis or the fascia to really identify the linea alba. So you make a precise incision. So you at least above the button or above the linea semicircularis don't open the muscle compartments. You don't want to expose the muscle.
And then if we extrapolate that now to C-sections, because I think, for most of the audience, the most common incision will be for C-sections where we make a Pfannenstiel incision, where some of us cut open the fascia, some of us tear open the fascia. Often at the corners, we come to the oblique muscles, and it's not always that easy to identify, the fascia and not grasp a piece of muscle. So your message there is to definitely try and avoid grabbing any piece of muscle there, not to get necrosis. Is that correct?
Yeah, because muscle is, if you take the oxygen away from the muscle, it will die and rotten and provide ground for an infection. So there's no good reason for suturing muscle or fat.
So luckily, the incisional hernia rate seems to be quite low after cesarean section.
Det är det. Ja.
Literature states 0.2, 0.5%. And Gabriel, we were discussing that maybe it's the background population that most patients that have a midline are older, they may be obese, they maybe have diabetes. A cesarean section is they're young women that are usually quite healthy and have good vascularization. Maybe it actually isn't maybe it's more the population that lowers the risk so much rather than the incision. Because if you look at in hernias after gyne surgery, it's about 2%. And we mainly do a Pfannenstiel incision. So I think that it might not just be the incision, but the population that we perform cesareans on.
Gabriel, what's your thoughts on that?
If you use the Pfannenstiel as an extraction site for perhaps colorectal surgery or for urological surgery, you end up with a much higher incision hernia rate, 5 to 10%. But it's a very good incision. For at least, it's not a good incision to get access to the abdominal cavity, but it's a good incision to avoid incisional hernia.
Would you recommend that, because most gynecologists, I would guess, take out our specimens through the suprapubic, through a small Pfannenstiel, or vaginally. Some take it out in the midline. Would you recommend to take it out suprapubic rather than midline then to avoid hernia?
I don't really work. I really can't answer that question. I think the most important is whatever incision you do, you should expose the fascia enough to make a thorough closure of the fascia. So you really see what you do, and so to avoid complications in the wound.
Do you have any opinion about using clamps on the fascia or not? Because some people use clamps to mark out the fascia, and some say, no, don't do that because you destroy the fascia. Do you have any opinion?
No, but I mean, I think it's an unnecessary thing to do, because then you kill the fascia, at least where you put the clamps. I don't think you really need it.
Andrea, I want to follow up with a question on C-sections. You said, are certain populations higher risk? I know you looked at the literature. Can you elaborate on repeat C-section? Does our hernia rate increase with repeat C-section?
Yeah, so I think if you've had, after one C-section, it also depends how long you follow up. After one C-section, and then the rest vaginal delivery, about 0.2%. If you've only had C-sections, so over time, up to 30 years, it's about 0.8%. So it's a large risk increase, but it's still a small risk.
Two
This is Sweden's
C-sections, 3
data.
C-sections, 4 C-sections, the hernia rate increases.
The hernia rate increases per C-section, and and over time.
And we do more and more repeat C-sections.
And we do more and more repeat.
Yeah.
So if you do one, the risk is 50% that patient, about 40% that she will have a C-section her next delivery.
And then again on suture type, so I mean we've heard that the ideal suture is like a type PDS2 or other brand. I think many gynaes are used to using thicker sutures. I think there's a lot of habit of using Vicryl as well in gynecology. And I know that in oncology for a long time there was a habit of using a thicker looped suture. Maybe Gabriel, can you explain why the loop is not stronger? Why should we not be using that anymore?
So if you go back to the randomized trials, one of the problems with those studies is that they use 2-0 for the 2-0 for the small bites and 0 or 1-0 for the large bites. I'm not sure whether it does. I don't think it does so much difference if you have a 2-0 or 0. The most important thing is that you have a small needle, because a large needle tempts you to take big bites. So a small needle is making the closure with small bites much easier. So I think the size of the suture is less important. But you should, at least European Hernia Society advocates that you should have a slowly resorbable suture, not Vicryl. And there are some different types, of course. There are the polydiaxonon and there are the monomax. But it should be, it should not be a non-resorbable because they give you more pain.
Great.
I think we have a question from Prof. De Campos.
Yes, exactly. Diego, please go ahead.
Yeah. Oh, thanks again. My question is regarding the 4-to-1 ratio of the length of the stitch versus the length of the wound. And I was wondering that it seems to me that sort of when you finish suturing, then you know whether you've done it right or not, which is so it's a retrospective analysis of what you've done. I was wondering if prospectively there was any recommendation regarding the distance between the different bites that you take, rather than at the end seeing whether you've done it properly or not.
I can answer. So you should have 5 millimeters apart, the stitches, and the bite should be 5 millimeters from the aponeurosis cut. And it's really in my setting we apply that you redo if you don't come up to the good enough ratio, you redo. So you learn very quickly to be thorough in your closure.
Okay, so it's 5 millimeters everything, 5 millimeters between the stitches and 5 millimeters under the aponeurosis also.
Yeah, and you shouldn't forget that this should be tension free. You should not let somebody lift the patient with a suture. You should the suture should always be visible. So a light pull in the suture line.
Okay, thanks so much.
Thank you for the question. We have
So you don't recommend, Gabriel, the in the middle of the night suturing of the fascia, holding the suture with one hand, pulling tension, and then suturing with the other hand? Is that a no-no?
Ideally, you should have a device to make the closure, but when you pull the suture, you should have it between your index finger and your thumb, and just pull it carefully. Don't lift the patient in the suture.
That's a clear message. So thank you, Gabriel. We have a new question in the chat. I'm going to read it. And I'll ask first about, I think Gabriel has an opinion about this, I'm sure, but I think I'm going to ask it to Jan and see what's your opinion, and then we'll allow Gabriel to comment as well. We sometimes use corner safety sutures. What is your opinion on this? Jan, do you have an opinion, or?
I think for C-section, I think a lot of people are in the habit of using corner safety sutures. I do it as well, I'll be honest. So I think Gabriel advises us differently, but we should ask him. But I think we're all in the habit of doing that in C-sections. Absolutely.
So Gabriel, what's your opinion about corner safety sutures?
I have no idea. This is really a space for a lot of research. Nobody knows. But it's important not to involve too much muscle, because the muscle only rottens.
Maybe in a follow-up of that, can I ask you another question? In gyne-oncology, we tend to make very big incisions, you know, all the way from xiphoid to the pubic bone. With that, when we'll need 2 sutures to get to that length, starting on both ends, how do you advise to connect them in the middle?
Yeah, so first you should use a fisherman's start knot and a closure knot. You should that's probably the strongest knot. And when you meet in the middle, probably separate knots is the best, so you don't rely on a single knot.
So not to each other, just.
No, I think you should do separate knots.
Okay.
Great. There's actually one more question coming through the chat, and I encourage everyone. So please put forward any questions you might have. But the question here is from Louise in Trollhättan, based in Sweden. When suturing fascia at the Pfannenstiel, which ratio should be used? I think it's been touched upon already, but Andrea, what's your?
I've vacuum cleaned PubMed, and there's very, very little research done on obstetrical or of Pfannenstiel and caesarean closures. So mainly it's the research is done on midline closures, and then we extrapolate, or we try to generalize the data on the Pfannenstiel. But I have not found any comparing studies. So given the current literature, I think that we should follow the recommendations when it comes to midline, because it cannot be wrong. And if we can avoid the infections, and even if the rate of hernia is low, on a population level, since we do so many cesarean sections globally, we'll have a higher rate of hernias due to Pfannenstiel. So what we teach at our hospital is a 4-to-1 for Pfannenstiel, but there is no literature, not that I have found. I don't know, Gabriel, if you recommend anything else.
No, but I would never do a cesarean section, I think. But
you have.
Yeah. I think this is a very good research topic. In Sweden, there's about, is it 17,000 cesarean sections done annually? I mean, it would be very easy to perform a study to see what.
We have about 100,000 deliveries, and we have 18% cesarean in the country as 18,000.
Yeah, I would love to. If somebody interested to start a study in this field, I would love to collaborate.
But as long as we don't have those data, I would think fascia is fascia, so there's no reason not to adopt the 4:1 ratio in a Pfannenstiel, no?
Yeah, and we do have, I think it's more common, or maybe at least we see our complications with more acute complications like a fascia rupture 10 days post caesarean, because those patients we see. And if we can avoid that, I mean, it would be good.
I think another important thing to ponder about is that hernias after cesarean section is really tricky to reoperate, because you don't have so much space to work in, so it's a difficult repair to do, and with a high risk of reoccurrence of the incisional hernia.
And on our very high risk population, I'm thinking oncology now, but you can think of a patient for a C-section as well. You know, the sick patient, the immunosuppressed patient, the obese patient with repeat procedures. Is there any indication that we can prevent hernias by overlaying mesh?
This is a strong debate.
Prophylactically, I mean, yeah.
Yeah, so I think there's a lot of pros and cons. I think that European Hernia Society hasn't really decided on which leg they should stand, but there's been, the last 10 years, there's been many randomized trials with weaknesses and that have suggested a real reduction in incisional hernia if you put a mesh on, but you would add 20 to 25 minutes to the operating time, and you would leave the patient with a lot of foreign material. But probably there's a very strong industry push as well to put meshes on people as means to avoid incisional hernia.
Thank you. We have more questions coming through here, and there's a question about the size of the suture. And Margosia is asking, can we expect lower incision hernia rates if we take a PDS 0 instead of PDS 2.0 for obese patients, or should it always be PDS 2.0?
Yeah, 2.0 is good enough.
2.0 is good enough. Thank you, Gabriel. Yeah. I want to, as we have 15 minutes left of our time here. I'd also like to ask a question to the full group here, to the faculty. How do you think? How do we best influence and ensure that the gynecological specialty start using this technique, this small bite technique, in the best possible way? What's the method of spreading the word and the message? What do you think, Jan?
I think probably inform people at the conferences, but I think mainly try and get to the, sorry, my phone's ringing, to teach to the registrars who are in training and who in reality end up doing a lot of the cesarean sections, and make them aware of the importance of it, because I think there will be a group that knows about it or has heard about it. But this is going to sound ugly, but I think that there is a lot of laziness amongst us as well at 3 o'clock in the morning, and it's just quicker to close it with quick bites, and it's always been good enough, we think. So I think we really need to make them aware that it is really important, because it does make a big difference on a large scale. And then if we can find a way to make it faster, that will help as well.
Andrea, what do you think?
Yeah, no, it really is the same. We need, I mean, we need to get the information out to our specialty, that how to close the abdomen. And we're not, and within gyne surgery, we're pushing, and which is good, for more and more minimally invasive surgery, which is good for the patient. And therefore, we do less midline incisions and less Pfannenstiel incisions. We do caesareans, of course, and I think the focus on that surgery has shifted from that type of surgery, which is mainly performed for cancer surgery, and so I think we just need to go somehow get the information out to the gynecologists how to close the abdomen. Conferences, webinars like this. Our registrars are at the Department of Surgery for a couple months with rotation, and to get the information out. I don't know how other clinics do in Sweden, if they suture with PDS. It would be interesting to hear if that's what if this is new, if this is old news what we're talking, or if they've heard about it. Because in Helsingborg, since we've been, it was the surgeons that told us this is what you're supposed to do, and we said okay, and so we do it. Yeah.
I think what. Yeah. Can I just add one thing? Sorry. I think one of the problems, and then we spoke about C-section, but when I'm thinking about, more extensive cancer surgery, is we sort of feel the procedure's finished once we got everything out. And, it's the focus drops of the surgery because we're just closing. And I think, awareness or repetition on the importance will make us focus on this aspect of the surgery, whereas now it's often left, the main surgeon leaves the OR already and leaves the assistant to close, probably, but without giving thorough enough instructions on how to do it. I fear that's a bit the reality. It shouldn't be like that, but I do see it's like that.
We have a couple of questions coming in here as well. Please help me here if I'm not getting this question the right way. Fascia edge suturing technique, far to near edge and near to far edge continuously. I would put this to if you understand the question.
I understand the question, but I'm not familiar with the technique. The beauty of the 4-to-1 technique is that it's pretty easily reproducible, and the best thing is that it's also easily checkable. If you measure the rest of the suture and you know how long the suture is, the wound is, then you know that you performed well. So it's a very easy technique, and I think ease of use is very important for surgeons.
Yeah.
To implement, I mean, it's important to implement techniques, ease of use.
Great. Thank you, Gabriel. One more question, and I will put this to you, Jan. In laparoscopic surgery, from what dimension do you close the fascial defect?
Anything from a centimeter I close. So from a 10mm trocar, again, I think, Gabriel, you have more expertise, so we should ask your advice, but that's within our 5mm we don't close, and the 10mm we close with usually just with one suture. And anything above, obviously.
1 centimeter. And what about you, Andrea?
The same.
Same, yeah. Gabriel?
And we close it with PDS, even if it's just a centimeter. With a double stitch or something.
That follows the recommendations from European Hernia Society, 1 centimeter.
Not always that easy in an obese patient, eh?
Yeah, but more important on the obese patients.
Exactly.
Also.
Do you have any tips and tricks from the Department of Surgery, if it's this much fat and a small hole, do
You
you
can
use
use
an instrument, or do you have a...
you can use the fascia closer device. It's much easier before you take the last port out.
Yeah.
Great.
I'll show you, Andrea.
We have no more questions coming in through the chat. Please, if there's anyone, we still have a little bit of time left. So if you feel that there's something you want to know from this distinguished faculty, please raise your hand or put the question through the chat. Yeah, I see. Oh, here we go. Another question. In Sweden, residents in gynae surgery have mandatory course basic surgical technique where the 4-1 principle taught. Is it the same in Belgium?
I don't know. That's the honest answer. They do have basic surgery courses, but I haven't been to one, so I don't know if they teach the 4-1. I don't know.
May I ask the listeners? Do you, at your clinics, is the 4-1 ratio used after being trained to use it? Is it implemented, or is it, as I think it is at night in Helsingborg, that
I think we lost Andrea there, did we, Jan?
I can't hear her at the moment. Yeah.
No.
I think she. Yeah. I think her question was what are people doing in practice? I don't know if we can sound out the audience, or if anybody wants to comment from the audience.
There we go. Now Andrea's back. But anyone in the audience, please, if you want to either write in the chat or maybe unmute yourself and comment on this question. I think there's someone here. No? Anyone who wants to comment?
Yeah. My name is Thomas Bosberg from Sweden. I'm a senior gynecologist and oncologist as well. I have had these courses in basic surgical training for many years in Sweden for residents, and we do teach this principle based on both papers you have presented. But still, the tradition when these registrars residents come back to the clinic is that the tradition amongst gynecologists still is to use Vicryl, for example, or is older techniques. So they have actually problems in implementing this when they come back to their formal clinical training.
Thank you very much. Thank you very much for the comment. And I think that's in line also what we see here coming in, some comments on this particular question in the chat. Someone is writing 4-1 technique is new to me. Someone is saying that it's not formally trained in France, but there's a small bites, yes, but not 4-1. Someone says the resident do not do, but among the older colleagues, it's not so often done. Sorry, the residents do, but among the older colleagues, it's not so often done. Yes, so it seems to be a mixed picture on this one, I would say. Here's another comment. We use the 4-1 technique, but rarely do the string again if not tight enough. So some type of awareness, but maybe not fully implemented is the summary. Yeah, Gabriel, please go ahead.
Yeah, comment on that. Even though this technique is advocated in guidelines, both European and American guidelines, implementation is really hard, and I think there's a few reasons. It takes a little bit longer time, not much. It takes about maybe 10 minutes longer time. And I think it's cumbersome to do it when you somehow treated the patient, and that implication is really difficult, has been shown both in a big Dutch study with inquiries. I think 35% of the Dutch surgeons said that they were using this technique, and similar American studies showed that less than 50% this technique. So implementation is tricky, but for me it doesn't really make sense. Maybe you spend 2 or 3 hours doing a surgery for a patient, and then when you will finalize and close the patient, you don't perform as good as you could, and it's only about 5 or 10 minutes extra work. So I think that's very odd, and it's important to spread the message about the 4-to-1 small bites technique.
We have 2 more. Thank you very much, Gabriel. That was a very good summary. We have 2 more questions, and then we will have to start closing the webinar. As a question for you here, Andrea. In a Pfannenstiel incision, you always close with a single continuous suture and not with the 2 sutures, right?
We do that, 1 running suture.
From each angle to the middle? To the
No,
midline?
from one corner to the other corner.
Okay.
Because usually the incision isn't that long. Maybe it's 10 centimeters, 11 centimeters. So a midline, well, it depends how long the midline is, but one running suture with PDS is 2.0 is good enough.
Thank you. And one last question here to Jan, and then I'm going to allow Gabriel to close. So a question to you, John. Is it as important with the 4-to-1 with the Pfannenstiel as midline incision?
Yeah, I think that's what Andrea said earlier. We don't have the same level of evidence as we have for a midline incision, but I think, you know, we still have hernias after Pfannenstiel incision, and fascia is fascia. So I think the best evidence we have comes from midline. So I think there's absolutely no reason not to implement that in Pfannenstiels as well.
Perfect. Yeah, I think that's a clear message. Thank you very much, John. So Gabriel, before we close, would you mind if you please summarize a little bit of your thoughts and your perspective on the conversation that we just had?
Yeah, I think it's really nice that so many gynecologists joined us today. This is, for me and for us, it's an important topic. Use the small bites technique, use small needles. Don't lift the patient in the thread. Just use your index finger and your thumb to stretch the thread while you're closing, and measure how much suture line you put in the thread, and you'll be fine.
Perfect. Thank you very much. So let me allow me to thank you, the faculty here. Thank you very much, John, Andrea, and Gabriel. Very insightful and valuable conversation. It's been a pleasure listening to all of you. And a big thank you for everyone who participated in the webinar, and thank you for your interest and all your questions that has been coming through. Please continue to follow this conversation and any other news that you can find on the Suturion website. You will find that under news section, and there will be some other updates moving forward. And hopefully we'll be able to arrange similar webinars again in the near future. So please enjoy the evening, everyone. And again, a big thank you for joining. Take care and have a good evening. Bye-bye.
Thank you.
Thank you.